Hello, and welcome to Breast Cancer Conversations, a podcast brought to you by survivingbreastcancer.org. I'm Laura Carfing, breast cancer survivor and founder of survivingbreastcancer.org, a nonprofit organization providing community, education, and resources to empower those diagnosed with breast cancer and their caregivers from day one and beyond. Hello, my friends. I am so excited that you are joining us for another episode of Breast Cancer Conversations. I look forward to not only having you listen to our content, and I want to welcome you if you are new to Breast Cancer Conversations. This might be your first time tuning in, and I look forward to you attending some of our virtual programs that we offer through survivingbreastcancer.org. So before we get started in today's amazing podcast, I want to make sure that you know how to get in touch with us and take advantage of all of the free programs and services that we offer. The best way to do so is by going over to survivingbreastcancer.org/events, where you'll be able to RSVP for programs in English and or in Spanish, such as expressive writing, art therapy classes, our breast cancer book club, where we read books that have nothing to do with breast cancer. We have our Thursday Night Thrivers weekly meetup groups, programs for inflammatory breast cancer, programs for people living with metastatic disease. In addition to our website, you can always follow us on social media. Our Twitter handle is SBC_ORG, and Instagram is survivingbreastcancer.org, all one word. Well, welcome everyone to another episode of Breast Cancer Conversations. I am so excited to be starting the conversation with these three amazing women. We have Adriana, Vanessa, and Brenda joining us today, and we're taking a deep dive into DIEP Flap surgery. This is a type of surgery that is an option currently to people who have been diagnosed with breast cancer. And I think not only are we going to hear stories about breast cancer and the three unique experiences of Brenda, Vanessa, and Adriana, but also I think it's important for our listeners to know kind of the history around breast reconstruction. The Women's Health and Cancer Right Act of 1998, WHCRA, is a federal law that provides protections to patients who choose to have breast reconstruction in connection with a mastectomy. This act is a big deal. Whether you have been diagnosed with breast cancer or are considering a prophylactic mastectomy because of a genetic mutation, this protects you and enables you to get breast reconstruction. At the end of the day, no one is asking for a breast cancer diagnosis. There is a lot of emotional trauma, mental, physical, everything that we are dealing with. And so today, I'm hoping that we're going to be able to talk and shed light on what DIEP Flap surgery is. You know, it's an acronym that we use in the breast cancer space. We use a lot of acronyms, and I had to use a lot of new vocabulary when I was diagnosed. But from there, too, I think if it's someone's first time listening and they're still considering their surgery options, I think the three of you today can really share how you've come to this decision, how you decided a DIEP Flap surgery was best for you versus implants, and the unique experiences. So I'm very excited to have all of you here today. So thank you.
My name is Vanessa Vance, and I'm 45 years old. I live in Austin, Texas with my husband and my 8-year-old son. And my breast cancer story is one that is not yet. I'm lucky. I'm one of the prophylactic mastectomy candidates. And so I have a long family history of cancer, and maybe my mental model isn't very good on this, but I've always kind of thought that I would eventually have breast cancer. My mother and my aunt had numerous cancers. My aunt had 2 breast cancers and just saw them fight for years and years and years. I was tested for genetic testing in 2015 when I had a cyst on my breast, and, it said pathologic variant, and they were like, just do diet and exercise. And I'm somebody who's struggled with my weight my whole entire life. And so diet and exercise, it makes sense, but it wasn't something easy for me to do. So I'm like, okay, well, I will try. And I fell off a follow-up with the providers. They fell off a follow-up with me. And fortunately, I had an ovarian cyst rupture in June. And I was like, wait a minute. What did that genetic test say? And so I went digging through my files and I'm like, oh, I have a big ovarian cancer risk. And then I went to the the company that did my genetic testing, and I just put in my variant names, and then boom, the recommendations had completely changed. And so my messages for self-advocacy is to know anybody who has either a variant of unknown significance or a pathologic variant, the recommendations and the science are really fast, quickly improving. And so what was no intervention is now recommending lots and lots and lots of surgeries for me. And so my two genetic variants, one is called PAL-B2 and one is BRIP1. And I think of them as like the little sister or the little cousin of BRCA1 and BRCA2. And so my BRIP1 will give me about a 15% risk for ovarian cancer. So it was in the fall of 2022 that I, really got my records together, really figured it out. June was when I had the ovarian cyst, but I was like, hey, I'm still having this pelvic floor pain. What is this? And, that's when I started. My first practitioner kind of blew me off. And, I didn't take the active role in the driver's seat. I blew myself off for a little bit. And then, by happenstance, I got in with another GYN and, they knew right away. It's like, oh, this is a medical center. And they were like, yep, we're here to talk about your pelvic pain, but let's talk about these very important things. He's like, let's get you set up with genetic counseling again. And the emotional response when you go to genetic counseling, I have such an empathetic genetic counselor and she presented everything really fairly, but I wasn't really ready to hear some of the things she was saying to me in my counseling. And so, but she laid the foundations for choice and options and what was right for me and what's right for my story. And then it trickles down to my entire family. Because even though my aunt and my mother had all of these cancers, breast cancer numerous times, I'm the first one. I'm the first one in my family. So, and we're kind of a family that we like to wait on things, And so, so here I am kind of like knocking on the door of all my family. My family doesn't want me knocking on their door. They're like, no, thanks. So it gets this interesting family dynamic as well. And like MD Anderson, they did one of my first surgeries and it's a research study and they got so excited because, oh, we haven't seen this yet with these two variants. We'd love to do a case study and publish it. So, I'm knocking on the door of all my family and they're like, no, thanks.
It's very touchy. And, and I'll link in the show notes and everything on our website too, the education we do around genetic testing, right? And so I too also had a variance of unknown significance. And so that typically is treated as if it were, benign, right? Like if you have a variance of unknown significance, you're not positive for some of these genetic mutations. And so, you don't necessarily need the mastectomy, et cetera, right? But I think to your point, Vanessa, is so important that someone should have followed up with you as soon as that variance tipped the scale, because once that genetic lab gets enough data, well, they'll be able to be in a position to change what the recommendations are, right? And even from 2015 through now, where are we, 2023, the panels now for testing genetics have expanded. And so very similarly, I think it's something that we need to stay up on and continue to knock on those doors, as you say.
Yeah. And definitely it's kind of like a 3-part shortfall because the company that tested me, the breast surgeon that I saw, and the genetic oncology. So it's like 3 different professional services knew of me. And, there's just like a failure rate on follow-up. And I guess in my own individual learning as being the first one in my family is really honoring choice for others and really learning informed consent and learning to walk the line of kindness for my family. And so, like I have to hold my anxiety in one hand for them and kindness in the other, and then be like,
yes.
Just because, we'll talk about this later on more with the insurance pieces that are happening with DIEP Flap. But I did, contact my sisters recently. I was like, hey, I have a lot of anxiety about this. If there's a 2024 deadline, can we talk about this? Like, can you make this feeling in my body go away? I just need to make sure that so that I can stop thinking about it. And they were very kind to help me through that and relieve that worry.
Yes.
So.
And a lot of people aren't ready to know their genetic testing and not ready to make those choices as well, especially if you have, younger siblings or sisters or even your children that you might worry about passing something on to them as well. So it's quite complex, and yeah, it doesn't hold space for all that anxiety. I like that you wrap it around some kindness. So thank you for sharing that. Brenda, can I turn things to you as someone who's been diagnosed with breast cancer, at a little bit of the journey you've been on and where you are currently?
Yeah, I was diagnosed 1 year ago. I'm located in Maryland. I'm originally from Mexico, from Monterrey, Mexico. So I was diagnosed, as I mentioned, 1 year ago. And at the beginning, the doctor told me that I was a candidate for lumpectomy or single mastectomy or double mastectomy. But when they did the MRI, they found some suspicious tissue on my other breast. So when they did a biopsy, and they said, well, it's not cancer right now, but it can develop later on. So I just opted for the double mastectomy, 2 expanders. So right now I have the expanders. I went to chemo, radiation, and I just finished radiation or the active treatment in February. After a month later, when I finished my radiation, I went with my plastic surgeon, and he mentioned that the tissue is very, thin. And he's not recommending for me to get implants. At the beginning, it was the option of the implants, but he's not recommending it anymore because it just got thinner. So that's why we scheduled the DIEP Flap for September this year.
Great, thank you. And Adriana, I'd love to hear a little bit about your story and where you are as you're considering your surgery options.
Yes. My name is Adriana. I am a triple negative breast cancer survivor. I was diagnosed June 2020, right when everything began on the whole thing that went down. So that was crazy.
The thing we shall not mention.
Yeah. Found my lump in March because of everything that happened and a few things in between. I didn't get a biopsy till June 19th. And then a week later, that's when I was diagnosed. So fast forward a bit, it's triple negative. My first oncologist then, obviously, the running joke in triple negative is, oh, it's negative. Oh, that's a good thing. No, it's a bad thing. So that was interesting to learn on that part. So we did a full genetics panel. Initially, I was diagnosed with, came back positive for BRCA1 mutation. Which was very interesting, and kind of to piggyback a little bit off of Vanessa. Growing up, I knew I was going to get breast cancer. I knew it. I always knew it. When I found my lump, I found my own lump in the shower. I'm like, it's cancer. As bizarre as it sounds, the reason I state this is because of my family history. And this goes so much to show with Vanessa and what she is saying. Every year I went for my physicals. Sometimes I would go multiple times a year to get any, medical, any prescriptions refilled. And they always ask you about your history of XYZ health issues. They have you fill out everything all the time. I always explain to them, I have lost immediate family members on my paternal side, which was at that time was 3 aunts that died of metastatic and ovarian cancer. So the red flags were there, but I don't understand where and why nothing was ever done to raise the flag in my medical teams that I saw throughout this time to say, hey, let's do a genetic testing panel. Let's get that going since she is bringing this up every time. I do remember I did have a scare when I was probably like 19, 20 years old. I remember going in and they did an exam because I had felt something. But they said it was nothing, so I didn't push it. That was many years ago. Here we are, 2020. It's found. I, get BRCA1. I had 14 rounds of chemo. I had a double mastectomy and a total hysterectomy within 4 or 5 months of each other. That was a lot for my body to handle. So I had those surgeries, and in between this time frame is when I was meeting with plastic surgeons for my DIEP Flap surgery. And in the beginning, everything was great because when I initially saw my surgeon, everything was fine. There was no issues. Nothing was discussed to me of, any red flags, what to do, what not to do. Just, hey, this is a DIEP Flap. This is how it works. Something I already wanted from the beginning because I did not want any implants. It was just a surgery that I wanted because it was so natural. It was my own body. It was my own tissue. And it's just something I wanted. So fast forward a few months after my double mastectomy, when I was already going to start meeting with surgeons and kind of, get the ball rolling with that, since it was determined that no active treatment was going to be done after. So then I start scheduling. I meet with a different surgeon because that surgeon wasn't available. Everything was going great, had it scheduled. Then that surgeon at that time says, unfortunately, your BMI is too high. And I said, whoa, but nobody ever said anything from my initial first surgery, plastic surgeon appointment to now. Clearly I gained the weight because of chemo treatment and steroids and everything. It was all out of my control. I didn't do this, So to me, I was like, what? And so that kind of, that set me into a very dark place. Because now I am being told I cannot have this surgery because of my weight. So it's tied up to something that made me feel like it was my fault. When my entire journey has felt that it's not my fault. And I know it's not my fault. So now I feel like this little part that I've been like hanging on to everything by a thread, I'm being told I'm overweight. And I'm like, what? So
and there's so much complication too with, and I was diagnosed similarly in my 30s. You were 32 when you were diagnosed with triple negative. I was 34 when I was diagnosed with triple positive breast cancer. And now I'm about 5-6 years out, and I'm dealing with still all of the health trauma of all of the chemotherapy, all the toxicity, the scar tissue, the radiation, cardiovascular risk, et cetera, has just exponentially grown. And I think to your point is I just want someone to say it's not your fault, right? I want someone to say, like, you're doing the best that you're doing. And it's because we gave you all these steroids. It's because we gave you adriamycin, the red devil, like all of these things, right? Herceptin that hurts the heart, all of these things, right? So it is not your fault, but I completely hear you that we get so far and we're so fragile in this vulnerable space that the what is it? The thing that breaks the camel's back, right? That you're just like, that's the thread. That's the thing that does it. So I definitely want to get back into the BMI and kind of some of these complications. But before we kind of dive deep into that, I want to maybe look to Brenda or Vanessa also when we're talking about identifying surgeries that are good for us, that are a good fit for us. Brenda, how do you feel in terms of, you kind of were thinking about expanders going into implants, and then now after this conversation, is there a grief or a loss because you can't have the implants? Or are you comfortable with this conversation of needing the DIEP Flap surgery to use your own tissue? How did that go for you?
I'm scared because of all what it takes, the DIEP Flap. And that's why I wanted it to do. And my first thought, it was like, yeah, it's good at DIEP Flap, so I don't have for anything out of my body, like an implant, right? But then I was like, well, but I'm scared about all the month in recovery and spending a week in the hospital. So that's why I was leaning towards the implant. It did feel like a loss that I don't have that option anymore. But I mean, I'm comfortable with because it just put me back to, well, you're not going to have some thing that is not yours. It's just going to be the same. So I'm kind of in between feelings. I'm still scared, obviously. And I'm preparing, I'm bringing my mom here. So she spent the time with me and helped me and my husband. But I'm still scared, but I'm taking it at the end of time as these processes, and just looking forward that now we have a plan to finish this part and try to feel back again.
Another milestone to check off the list for sure.
Yes.
Vanessa, what about you? Were you when you found out your genetics results, were you investigating other types of surgery options, or did you know that you always wanted the DIEP flap?
I initially was drawn to the Goldilocks, which is basically if you have a large chest and maybe hanging skin, that they can kind of fold you back up and make like kind of a star shape, keep your nipple, and then you kind of get like a little, they call it a ballet cup. But I was turned off because I found out that, you know, the wait list is 2 years for the people who are really good at this Goldilocks, and you'd have to travel to California. I live in Texas. And the thing that really turned me off is, you know, and these, I didn't call the office to verify this, but the people on the Facebook groups that follow the surgeons specifically who've had the procedure talked about like, oh, you have to put $39,000 down cash for the Goldilocks procedure. And it felt really wrong. And, you know, you know, I have 20 years plus experience as a nurse, and part of my journey right now is working in insurance. And so, you know, I read about the Women's Health and Cancer Act of 1998 every day as part of the medical and nursing policies. And so it felt like ethically like a big rub. It's like what should be covered by insurance, and you know, it's not using something foreign in my body. It will have less surgeries. This is good for the patient. This is good for the healthcare system, less burden. And the plastic surgeon wants to charge $39,000. You're like, that doesn't feel right. It should be covered by insurance. Like, why? And then, you know, through more reading, somebody had posted, one of the originators, Dr. Ma, who's based in Georgia, you know, was talking about the people who aren't comfortable with their results from the Goldilocks. You know, they just needed to kind of be honest with themselves and realize like, it's not that you're not happy with the results, is that maybe you weren't honest with yourself from the get-go about what you truly wanted. And that was kind of the light bulb. And I was like, oh, when I'm looking at these pictures, if I'm thinking it's the surgical technique, or if I'm thinking it's the body type, you know, the results don't feel aesthetic all the time when you're looking at other people's pictures. And I was like, oh, it's that I really crave the softness of a breast and real tissue. And that's when I became more open into the DIEP flap. For me, implants wasn't really an option just because I just have a sensitive body, and putting something foreign in my body wouldn't really work for me. But it's a privilege to have that option because the recovery time is quicker. They're making all these advances where now they're putting the implants in front of the muscle some of the time. You know, I would love to hop in a DeLorean, you know, Back to the Future style, and go 10, 20 years in the future and have all of these breast reconstruction surgery options improve. I would love to have my surgery 15 years in advance. And, you know, the way that Dr. Peled and her husband are connecting the nerves, you know, like the thing that I'm struggling with right now is a great loss. It's like, well, when I came to the DIEP flap, I was like, oh, I can touch myself. I can feel this soft tissue. But no, you know, the innovation isn't there yet. And even if it is there with Dr. Peled and her spouse, who's also Dr. Peled, the insurance company considers it experimental. And so they're asking the patients to pay $25,000 cash for the connection of the nerves. Now, they might work with the patient and come to a lower number, but, you know, that's where it starts out. So this is big money. This is more than a car. You know, it's not a house payment, but when, you know, and again, I'm privileged because I'm in the prophylactic group, but my friends who have already gone broke on all of these chemotherapy options, if you happen to be ovarian cancer as well, like, you know, if you get the kind of chemo that's in your abdomen, like you're paying $25,000 for the privilege of that. And, you know, we have the capability of advancing the science. And I would love to receive my breast reconstruction 25 years in the future, because my prayer is that the Women's Health and Cancer Act of 1998 becomes the Women's Health and Cancer Act of 2024 and protects all of us and protects the scientists and the surgeons to develop this amazing care for women, and to really do what reconstruction is supposed to do. It's supposed to restore you to what you already had, you know.
Mm-hmm.
And if we really just support these surgeons, it's such a tiny little group of surgeons. Maybe there's 200 in the country that are doing microvascular surgery. You know, the other influences that are going on right now in the healthcare system are really going to extinguish this innovation. And so I'm saddened to think about losing options and access to, you know, like right now we have, I guess, 4, right? So you could go aesthetically flat, you could try the Goldilocks, you could do implants, and you could do the DIEP flap. It's like, well, wouldn't that be great in the future in 15 years if we had more options, you know, because
Yes.
each recovery is so different and each family system may or may not be able to support that person, or their health isn't able to manage that level of care. So I would love to
Yeah.
keep supporting these surgeons and keep improving the innovation.
100%. I think, I don't know if they're still offering this too, the lap flap, where they take tissue from the behind your shoulder area as well. And after I had neoadjuvant chemotherapy, so I became a candidate for a lumpectomy. But prior to that, we were considering that type of surgery. And I remember, very similar to your stories, like weighing the pros and cons of, do I want another surgery? Should I just go flat to have it be quote unquote easier, right? Less opportunity for risk. I was very active at the time. I was nervous that I would never be able to do a push-up again, or like, what does that mean for my muscles and my flexibility and the active lifestyle I was living? And so all of these became factors. And same thing, I was a vegan at the time and I didn't want to put these foreign objects in my body. It was mentally like every day I was in a new Facebook group, like, what should I do? What should I do? So I understand that. And it's scary that we are in a situation where we have to advocate for ourselves so strongly that we're, to your point about, you know, losing your sensation when you're going through breast surgery and breast reconstruction. A lot of people might not even know that they're going to lose sensation until after the fact. And I know the doctors do the best that they can to tell us of all of the risks and the side effects. But when you hear the word cancer, everything else kind of shuts down. And so I always say it takes, 5, 10, 15 times to hear the same information for us to really comprehend and accept the challenges that we're going to be confronted with. So the fact that as women, it's already, I feel like sometimes the cards are stacked against us. And now when there's innovation out there and things that are available to us, it is the systems that are no longer supporting us. So how can we marriage the two? All right, so we talked a little bit and we've been talking about this DIEP flap. I want to talk specifically about what the DIEP flap surgery is. What are some of the risks? So I'll look to you, Adriana, again, to talk a little bit about your experience with the BMI situation. That's not anyone's fault. And then also talking about the changes in insurance that is actually putting this type of surgery at risk. And what's so infuriating about that is because we don't want to set ourselves back 10 years, 20 years in more archaic surgeries that have higher risk for complications, higher mortality rates, all of these other complications, et cetera, from, in my opinion, what looks like, I just want to save a few bucks. You're not actually putting the patient first. And then secondly, I think what you are drawing upon in our conversation right now is if they're going to start chipping away at these options, this is a slippery slope. And what's going to happen when we do want to be so excited about the advances in breast reconstruction and breast cancer care 15 years from now, that we want to have even more options, not less. So kind of setting the stage for this next chapter and segment in our podcast, because this is really serious. I really appreciate all three of you sharing your experiences of where you're coming from and what got us here. You all have your surgery dates coming up, and we have this December 2024 date looming over us, that this may no longer be, the DIEP flap surgery may no longer be available to those diagnosed with breast cancer for reconstruction. And we're also experiencing now some doctors already not offering this to their patients or declining this type of surgery to their patients in advance of 2024. So there's a lot going on. I appreciate everyone listening and taking this so seriously. Brenda, I want to start off and kick things off with you. Has this come up at all with your breast surgeon? And have you had a review of actually like what is the DIEP flap surgery and what they're going to be doing to you day of surgery?
Yeah. So my doctor I asked them before scheduling about if I'm gonna be and have an issue with my insurance. He mentioned that the code that he uses, it's not a problem for the insurance to approve it. So it depends on the coding that each surgeon uses. I'm not sure what the code he is using, but we did have that conversation. Mm-hmm. What's going to happen with the surgery? So what I know, what we have spoke, is that he takes the belly and sutures it to the muscle, and that's what becomes the breast. So basically the belly becomes the breast, and it's suture, because I thought like, well, am I going to have like a net or something to hold it, or how's that going to feel? And apparently he sweats to the muscle, and that's how it becomes. The recovery is way longer than implants. Normally you stay like about 4 or 5 days in the hospital, and then you have to be very careful and not over move, because it's a major surgery, because you got the belly and plus the new breast. Mm-hmm. So you have to be very careful, not very active for about a month. And then 6 to 7 weeks is that when you can go back and do certain things as normal. But obviously it's going to take longer than just a month or 2 months.
Sure. I'm glad you're proactive and already talking to your doctor about that and the different codes that they're using, so that you're still eligible to get this type of surgery. And Adriana, your experience has been a little bit different, kind of shopping around for a surgeon willing to support you in this endeavor.
It sure does feel like I'm shopping around. that is the key there. It's so interesting hearing Vanessa speak on this, because I see her in her chapter, the before, where my life could have gone, and I am that experience after, where I feel like we could unite in a sense to like collaborate and just pick each other's brains to like have this evolve into something just like so informative. It's so bizarre. I felt that connection with Vanessa. I just had to throw that out there. Just because she speaks to me of things I like to learn, and I like to educate myself, and I feel like knowledge is power. And just to give a tidbit to that, and this is to tie in to why I'm shopping around and why it's leading into this, because I lack the knowledge to advocate for my health. I could do so much with every aspect of my life and learn to advocate, speak up, and do XYZ. But when it came to my health, I failed myself because I didn't educate myself. I didn't inform myself out of fear, because I just left it in the hands of the medical professionals. And there's nothing wrong with that. It's just every single one of them works differently, and it's not going to be tailored to what I want. And I have learned now that is how advocacy works. You have to speak up for what you want, what works for you, what's going to be of a benefit to you, not a general guideline. You're not standard. I am me. I am my own body.
We're unique, for sure.
Know, exactly. So I've learned that now, and this is where I've just tried to learn and observe so much, and hence why I've already seen my 5th plastic surgeon for the DIEP Flap breast reconstruction, specifically for this one. Because from the beginning, I did inform myself in regards to implants versus this type of breast reconstruction surgery and the flat aspect, because right now I am flat. I have no expanders. I have skin and bones. When it came down to implants, I saw a lot of images of how it looked. It was something that I didn't want, whether it be under or over the muscle. That does depend. And a lot of things come with that as well. So I automatically wanted the DIEP Flap surgery. And I have met 5 surgeons, 4 of which that are in network, 1 of which that is out of network. Out of those 4 in network, 3, unfortunately, do not want to perform the surgery due to my BMI, which I'm very open about, is at a 37%. It's still a high number, but it's not a scary number. It's not a scary number. And, and those 3 surgeons out of those 4 that are in network, unfortunately, will like me to lose 50 pounds. And that threw me into a dark spiral point in my life, because I was like, oh my gosh, how do I lose this? And I did different things to lose weight, and a few things did cause a bringing back of my PTSD through my chemo days because of the nausea, the vomiting, the fatigue. So I had to step away from that. So I have to, for me, what is working for me, the only way is through eating better and exercising. However, I am going through menopause because of my total hysterectomy. So all these challenges, along with trying to heal through this trauma of cancer to try to lose weight, and the limitation that we have of 2014 with this surgery possibly not being accessible to, a wide variety of surgeons that could do it within network and is going to be available for what we have to pay out of pocket, is a scary situation. Mm-hmm. Can I lose 50 pounds within that time frame? Let's be honest, no. I would have to starve, and that's not healthy. Hello, cancer here, genetic mutations. We can't do that,
And being thrown into menopause as well. I know a lot of us too, whether you had, the hysterectomy or if you're on a aromatase inhibitor or tamoxifen, your joints hurt. You're thrown into menopause. You're not breaking down nutrients the way your body used to. It's the cards are stacked against us. And I need someone to say, you're going to gain weight and that's okay because of the medicine, not your fault.
Exactly. And, if the surgeons that, again, to be able to perform the DIEP flap surgery, you need to be trained. Not all surgeons are trained in this. I found this out. It is crazy. So that reduces the number of accessibility for us. And then you have to have the surgeons that need to be within network to have that accessibility. So now we go from this pile to a very small, tiny little pile. And then you're going to have those surgeons that are going to, are they going to use BMI as an issue, And then I've recently met a surgeon where Vanessa lives in Austin, Texas, where if she wants to connect with this surgeon has performed this surgery on BMIs above 40 with no issue. It's just a technique. It's all in the technique from what I learned. It's the technique on how it's used. And, and it's just interesting with, with Vanessa and Brenda discussing this, the losing of the sensation was never spoken to me. And the only way I educated myself about it was through social media. Mm-hmm. I wholeheartedly believe my entire journey, I have educated myself via my very good support group that I have with a very good foundation that I'm a part of. And I have we just talk so much about things that pertain to this life itself. And, blood work, scans, tips, tricks that we all that is how I've learned. And it's unfortunate that it didn't come from my doctors. They did provide information, but not the entire thing that I feel I learned through social media and working with other advocates and connecting with other people in this situation.
Yes.
And I myself now am taking on that and in turn using social media as a tool to help people, because to a point of Brenda, many people don't know about DIEP flap surgeries and that being the option, because the surgeons may not be offering it if they don't do it themselves. So why would they offer a surgery if they're not performing it? But then as a patient, if you are unaware of it, you're just going to stick with that surgeon. You're just going to do it. And you're not going to know that there is options out there. But because we stick to one person only, one facility only, we don't inform ourselves because we don't think there's a reason.
We don't know what we don't know. And I think the work and the stories that you guys are sharing today is helping to get that word out there. I remember, talking with some friends who a couple years ago when we were just trying to advocate for aesthetically flat closure, it wasn't even an option. And now we're starting to see it more and more, which is, again, the work of the advocates and the work that we are doing collectively. So I appreciate that. Vanessa, I would love to turn to you with your background and knowledge on what's actually happening with the insurance codes. If you can kind of enlighten us on this crisis that we're facing.
So I guess just going through the big, long history, in the early 1990s, we developed the tram flap surgery, and that was coded for a long time with the 19364. And then in the 2006 time period is when DIEP flap was innovated. And so the CMS, Centers for Medicaid and Medicare, created a HCPCS code, and that's S2068. And, from 2006. So, sorry, let me pause for a second. When we said DIEP flap, I don't know that we've defined it officially. So,
please.
So deep inferior epigastric perforator. And so basically the tram flap used the blood vessels from the rectus abdominis, and that was the blood flow. So they would basically cut out your six-pack ab one side and flip it up to a breast if it was a unilateral reconstruction, and then that would be the blood flow supplying that new tissue up there. If you had bilateral mastectomy and bilateral reconstruction, they're going to take both of the six packs and use that to supply the blood flow to the donor site inside of the breast. And then with the DIEP flap, I think of it as kind of like, to me, it looks like a man of war. So you're going to take a big circular incision on your lower abdomen. And so your belly button most likely is going to get cut out. And then, that gets divided into two halves. And so there's two vessels or one vessel hanging down. So that's where I'm like, it kind of looks like the man of war. And then that's going to go into the breast that already had the mastectomy. So the breast tissues, the glandular tissues are taken out. And then that's the donor site. And then they connect in through the rib cage. I'm not sure which blood vessel it is that they connect into. And so those two surgeries, 40 years apart now, right? So tram flap in the 1990s and then now 2023, they impact women completely different. And as you spoke to the lat flap, that's going to take a shoulder muscle. It's very similar as far as impairing a woman or making her disabled, where she can't do her physical functions that she wants to, push-ups, burpees, getting up and down off the floor. With the tram flap, if you don't have your six-pack, you're not supported. Your spine supports the back and your six-pack supports the front. So when you don't have the support in the front, hernias is what's mentioned, but like massive back pain too, and just not being able to do life the way you want to do life. And so when they created this DIEP flap, they aren't cutting through the rectus abdominis muscle, the six-pack abs. They're just taking the skin and the fat and the tissue and the perforator vessel, and then the woman stays intact. And so she doesn't have an impact on her ability to exercise. She can lift weights. She can lift her groceries. She can lift her kids. Yeah.
Mm-hmm.
Like she can be a roller girl if she wants to, like you can do all the things you want to do. And so, with the different surgeries, I'm not sure if my son's behind me or not. And so, yes. Redirect me, Laura, back to what I was.
No, super helpful because, I think that's the crux of it, right? Where you have this tram flap that is taking your muscle, this archaic idea that is going to have a longer recovery time, increased complications, longer term risk with the hernias, everything that you were just mentioning. I think that's really important for our listeners and viewers to know, is that we've advanced from that. And so now, by reducing this ability for doctors to code for the DIEP flap, which is, correct me if I'm wrong, it was the S2068 code for DIEP flap. If that's no longer available, the only thing that they could code for is this tram flap, that's not progress, in my opinion. And
it's not. I don't understand, as a nurse and as a patient, there are different powers that be that are changing the coding, but just as a simple human looking at it, it doesn't make sense financially to put a really complex surgery, the DIEP flap, that requires a microvascular surgeon, only 200 in the country, and then equate it with any surgeon who can do the tram flap. And it takes much less time. And the DIEP flap surgeries, like when you listen to the plastic surgeons on Instagram when they're on with Dr. Potter's hosting, and they'll talk to you about how, hey, they're on call for 24, 48 hours after that surgery and ready to go back in if you have a hematoma, blood pooling in your breast area, to evacuate it. If you have a large seroma, if the blood flow decreases for whatever reason, if you have a connective tissue disease, if you have lupus, if you have a mixed connective tissue disease like Raynaud's, you might have a flap failure just because of your own health status. And they are there ready to see, can they unkink it? Can they get blood flow going through? Can they use another donor site really quickly? So it's not just surgery for X number of hours. And then when you look at the cost of surgery, so if you compare the price per hour that the insurance reimburses you for breast implantation is 3 to 6 times higher than the price per hour for DIEP Flap. And then for my own particular circumstance, I've read the research articles where it talks about the cost of me getting my mammogram and my breast MRI twice, 2 events in 1 year. They say to get them 6 months apart. That's going to cost them more than the surgery. And when you look at the research studies, it's like, so as a prophylactic patient pursuing an intense surgery to reduce my risk of cancer, I'm going to protect the insurance company from having to pay for cancer treatment, which is expensive. And I'm going to protect the insurance company for paying for breast MRIs and mammograms, which is expensive. And either one of these paths are my possible future. And by me choosing and my family to help support me through this recovery, which is more intense, I'm going to save everybody a ton of money. But back to the coding. So the Centers for Medicaid and Medicare, CMS, they met and they were requested by Blue Cross Blue Shield, an insurance company, to phase out the older code, the 2068. And what was presented in their literature basically said, that was more of a temporary code and this is more established. Can we eliminate that code? And then it's the American Medical Association. They're the ones in charge of making longer term codes. The CPT is the initial. And so the American Medical Association did consult with the American Plastic Surgery Society. I may have gotten that wrong. American Society of Plastic Surgeons. I think that's a better one. They did consult them in. Now, I don't know if they listened to them effectively, but the entity of the AMA and the American Society of Plastic Surgeons put the complex DIEP flap in with the old tram flap code. And then when the insurance receives this update, they're like, oh, we can't do anything about that. We're just billing with what the AMA told us to do. So everybody has this finger pointing and this blame shifting. And this is where in my gut, it just feels so wrong. It feels like a cover up. You're just like, wait, so all these powerful organizations did this to women, a protected class under the American Cancer Rights Act of 1998, and they're allowed to do it. And the end result is that, so the tram flap, which is a shorter surgery, it gets paid or reimbursed at a much lower rate than DIEP flap. And so if we were to talk about money, for example, hey, Jessica, if we were to talk about money, the DIEP flap, I'm estimating when you use the old code, the 2068, and doctors don't want to talk about money. They don't want to tell patients about money, but the amount of money we spend in healthcare is insane. We have no idea as a patient how much our healthcare costs. Like just a sleep study is $5,000, right? We don't know that as a patient. We're like, how would we know? But say they used to charge the insurance $50,000 for one breast. If you get 2 body parts operated on, the insurance company is only going to reimburse 50% less for the second body part. So maybe the provider could ask $50,000 for the right breast, and then for the left breast, they could do $25,000. Okay. Well, now when you go to tram flap, or, when you stuff the DIEP flap into the old tram flap code, the 19364, the providers, the DIEP flap surgeons, are going to get reimbursed 70 to 90% less. And just because the surgeon asks for the $50,000 for the first breast, they're probably going to get reimbursed at $30,000, right? These are all hypothetical numbers. But if you're just looking at a one breast situation, what a provider would have been reimbursed $30,000, they're going to be reimbursed like $5,000 to $15,000. And that doesn't cover the expertise of what's going on for that surgeon who's on call for the 48 hours afterwards, ready to jump in to help with complications, who is physically demanded upon their body. It's very demanding to do the surgery on their body. And the tram flap is not demanding on their body to do the surgery. So, it's not accounting for the effort that the surgeon has to do in order to bring this excellent care to us as patients. And all 3 parties could make a new move. Like, could the AMA say, oh, I'm sorry, we didn't realize. And in their literature, in their published literature, they all say, the American Society of Plastic Surgeons says, we don't expect any decrease in reimbursement. And the AMA said, we don't expect any decrease in reimbursement. Well, we've notified them, so there is a decrease in reimbursement, and it will affect access and options. Now women are being asked to pay out of pocket $30,000 or $50,000 for this surgery. So this surgery will always be accessible to wealthy women. And it's the woman who wants it in her community, in her city, with those 200, like if we're lucky enough to have one of those 200 surgeons near us where we can commute or our family can drive us there, that's going to cause a quiet quitting of these surgeons because they won't be financially able to offer this at such a low cost.
Absolutely. Thank you. Thank you for that tremendous overview and kind of like a pause for us to take that all in. I think it's something I need to rewind and listen to again, maybe a couple of times. And I want to ask, what can we leave our listeners with in terms of action items, right? So we have this information. We know it's a concern. What are the action steps we could take now to have these conversations with our doctors, call our legislators, get involved, and push this forward? You know, I think that I wish it was that simple that we could get the three players in a room, talk, have them hash it out and fix it. But we know it doesn't work that easily, right? So Vanessa, do you have any recommendations for like the advocacy side of what next?
I think I would follow along with the CBRA-alliance.org. And so CBRA alliance.org. So they are the nonprofit kind of leading the way. And initially we had been writing to our Congress people and Senate and US representatives. Right now they're asking us to pause on that. And, you know, the main thing is as a patient to talk about your patient story. And so that you can touch another person and say, because most people don't understand. They're like, oh, breast cancer, that's treatable. They don't know about, you know, the entire time after you're treated for breast cancer, you're sitting on pins and needles and seeing if cancer is going to come back in your body. You know, you're like, is it going to be in my bones? Is it going to be in my brain? Is it going to be in my liver? It's not like you go through the drive-through and it's done. Cancer treatment is not a one-off. It's a long-term chronic illness, and it doesn't go away once you have chemo or surgery. It's with you. And, you know, so right now my answer is share your own patient story. And for others, family members, neighbors, whoever, to actually listen to the podcasts that talk about the women's experiences, and you'll see how devastating it is for your life. How can you work after this?
Yeah.
I don't know.
Thank you. Yes, and that is exactly what we're doing at survivingbreastcancer.org. In Spanish with our Después de un Diagnóstico portion of our website on breast cancer conversations is sharing those sacred stories. Like, our voices are powerful. And I'm so thrilled to have Brenda, Vanessa, and Adriana here today to join us and share those stories. So thank you all for this important work. And thank you everyone for listening to our show. I would like to acknowledge that all of the information on our podcast are from personal experiences and are not a substitute for professional medical advice. You should always contact your medical care team. Our podcasts are made possible because of donations from listeners like you, so please feel free to make a contribution through survivingbreastcancer.org/donate. And there are so many ways to get involved with our nonprofit and our organization, not just through listening to the podcast, but through all of our virtual programming. So you can check out all of our lineups by hopping over to survivingbreastcancer.org/events. And as always, all of our programs, services, and resources are absolutely free. Thanks again and keep on thriving.